Hey everybody, today we're going to talk about the concept of perfusion, but we're going to focus specifically on medications for heart failure. Objectives of this session, we're going to identify the major diseases that accelerate the progression of heart failure. We're going to relate how the symptoms associated with heart failure may be caused by weakened heart muscle and diminished cardiac output. We're going to explain how heart failure is classified. Of course, describe your role as a nurse. We are going to go over about 4 prototype medications and discuss those, and then ultimately, again, talk about your role as a nurse, the nursing process, and patient education. All right, so heart failure is the inability of the ventricles to pump enough blood for the body's needs, or it could be a weakening of the heart due to the aging or other disease processes. Some common associated diseases with heart failure is coronary artery disease, mitral stenosis, myocardial infarctions or MIs, hypertension, diabetes, of course. There is no cure, so we can only prevent and slow the progression of this of heart failure. Now, when you're thinking about heart failure, you do need to know the difference between left-sided heart failure and right-sided heart failure. So a few examples that you would see with manifestations for left side. And when you think left side, I want you to think lungs. Blood's going to accumulate in the left ventricle for left-sided. The left ventricle is then going to thicken and enlarge, and that's called hypertrophy. You could see cardiac remodeling of the heart. Ultimately, the blood is going to back up into the lungs and you could hear crackles. Clients may cough, be short of breath. When we're thinking right-sided failure, this is where the blood is going to back up into the veins, and this is going to cause peripheral edema and organ enlargement. So I want you to think things like pitting edema, jugular vein distension, and hepatic enlargement. When we're thinking about preload, we're thinking about heart failure, we got to think about preload and afterload. So preload, this is going to affect the cardiac output. This is the degree that myocardial fibers are stretched prior to contraction. Based on Frank Sterling's law, the more fibers are stretched, the more forcefully the heart is then subsequently going to contract. Drugs that can increase preload contractility will then ultimately again increase cardiac output, and that's what we want. A lot of times these are called positive inotropic agents. Now, afterload also affects cardiac output, and this is when there's pressure in the aorta that must be overcome before the blood can get ejected from that left ventricle. These are going to lower blood pressure. Lowering the blood pressure, creates less afterload, and this is going to then result in less workload on the heart. When we're thinking about pharmacological management of heart failure, first we need to know that there's a couple of different classes or degrees of heart failure. So the very first one would be kind of mild. The client could have cardiac disease but no symptoms during physical activity. Class 2, again, they have cardiac disease and they have slight limitations on their physical activity. So for example, they may have fatigue, palpitations, dyspnea, or angina. And we'll talk a little bit more about that in our next segment. Class 3, again, has cardiac disease, but this is marked limitations during physical activity. And the final class would be 4, and this is cardiac disease. Clients are unable to perform physical activity, and they now have symptoms at rest. When we're thinking about mechanisms of pharmacology, ultimately the drugs that we're going to discuss are going to either slow the heart rate down, increase the contractility, or they're going to reduce the myocardial workload on the heart. So there's lots of medications that can be used for heart failure, hypertension, angina, and beyond. We're going to focus on a few specifics in this presentation, but right now I'm going to give you an overview of a few that you have. We're definitely going to talk about beta-adrenergic blockers in this segment, and these are going to decrease cardiac workload by slowing the heart rate. And then they're also going to decrease the blood pressure. Example of a medication in this area would be Lopressor. We're going to specifically talk about cardiac glycosides, and these are going to increase cardiac output by increasing the force of the contraction, the myocardial contraction. And we're going to talk about digoxin. We're also going to talk about phosphodiesterase inhibitors. These are also going to increase cardiac output, and they are also going to increase the force of the contraction. And an example would be Primacor. The other one that we will talk about in this segment specifically are going to be ACE inhibitors. Now, these are interesting because they work both in the arterioles and within the kidneys. ACE inhibitors have a thing that goes on with them with the conversion of angiotensin 1 to angiotensin 2. But ultimately, again, they're going to increase cardiac output by lowering that blood pressure, okay, and then decreasing blood volume. We'll specifically talk about lisinopril. Possibly a little bit later on, either maybe in this course and definitely in the program, you'll talk about vasodilators, and those specifically work on the arterioles. They decrease cardiac workload by dilating the vessels and reducing preload. And then diuretics, we will definitely talk about those sometime in the very near future. They are going to increase cardiac output by reducing fluid volume and decreasing blood pressure. And a very prime example of that is Lasix. So we will probably get to that in our hypertension section. So just a little visual for you, kind of maybe give you something to connect some dots. One of the classes we're going to talk about first are going to be ACE inhibitors. And a little thing I use to remember ACE inhibitors, what names the medications are, is the pril sisters are real ACEs. So a lot of time ACE inhibitors are going to end in pril, like lisinopril. Looking at this graphic here, very important when you look at the right side of it, it says CHF, and that's a little mnemonic there you can use to remember things like cough when it's contraindicated. We're looking at hypotension and hyperkalemia. We'll talk more about that. And then first dose, what do you need to do as the nurse? All right, so ACE inhibitors like lisinopril, these are going to help reduce afterload, and they are the drug of choice for heart failure. They're going to help with excretion of sodium and water, and also lower the peripheral resistance and reduce blood volume, ultimately, again, increasing cardiac output. So the mechanism of action with these medications are to inhibit ACE enzymes and decrease aldosterone secretion. Primarily used to decrease blood pressure and again reduce blood volume, and they dilate the veins. It's been one of the most frequently prescribed drugs. Blood pressure is decreased and cardiac output is increased with these medications or with this medication. It's going to take about 2 to 3 weeks of therapy to reach maximum effectiveness, and possibly several months for cardiac function to kind of return to normal. A few administration alerts or considerations. We do want to make sure as nurses we assess blood pressure just prior, always. And then we need to make sure that the med is therapeutic and that we're keeping blood pressures in a normal therapeutic acceptable range. Always, again, be mindful with geriatric patients. They may have higher blood levels based on their decreasing renal ability, so that's going to affect the medication. And this medication has a pregnancy category C for first trimester and D for second and third. So it's really important that if clients become pregnant or a pregnancy is suspected, that this medication be discontinued. A few adverse effects. We need to think about first dose hypotension. So we're starting on a new med. We could become very hypotensive when we do that. So we have to talk and teach our clients about that. This medication tends to cause a cough. We'll talk a little bit more. Can cause hyperkalemia and subsequently renal failure. It's really tolerated by most patients, but the common adverse effects that clients are going to state are cough, headache, dizziness, orthostatic hypertension, and rash. Hyperkalemia can occur, so we always need to look at those levels. Other effects could be taste disturbances, chest pain, nausea, vomiting, and diarrhea. Although it's rare, we need to be mindful of what's called angioedema. This is a serious adverse effect, and you need to watch for disturbances to the airway, cough, they're not talking right. This is where um, everything's just going to be edematous and they may not be able to breathe. So go ahead and look up angioedema so that you can become familiar with what that is. Contraindications. Oh, let me back up. This does have a black box warning. Again, fetal injury and death can occur. So if your client has a suspicion of pregnancy or is pregnant, they need to discontinue this medication immediately. There are some contraindications, and this medication is contraindicated in clients with hyperkalemia or anybody who has experienced angioedema before. It should, oh goodness, cats are running around. Sorry, and it should not be used during pregnancy again. There are some drug-drug interactions. NSAIDs can interact with lisinopril and decrease the medication. If clients are hypersensitive, of course, we don't want them to take this medication. Lisinopril and diuretics together, and it's not uncommon to see that, could cause a more dynamic effect with that low blood pressure. And if this medication is taken concurrently with a potassium-sparing diuretic, this is only going to probably further potentiate hyperkalemia. Lab tests you want to look at when you're administering this medication. BUN and creatinine, of course, checking the renal, and AST and ALT checking the liver function. Herbal and food, we need to talk to our patients about excessive intake of foods rich in potassium. So I hope you're thinking, what kind of foods are rich in potassium? Bananas, potatoes. We want to make sure that clients do not use potassium-based salt substitutes. They should be avoided. I may have talked about this in another presentation, but we're not talking the Mrs. Dash here. We're talking those things that are on the bottom of the shelf in the grocery store. They are clearly listed as salt substitutes, so just tell your clients to stay away from those. Treatment for overdose. If a client has overdose, they're going to manifest with hypotension, and this is going to be treated with administration of normal saline boluses or a vasopressor. Now, we're not going to get specific into vasopressors for purposes of this course, but you just need to know that's what we would do. Oh, I love it. We're going to move on to our next prototype drug here shortly, but before we do, I want to introduce you to Lizzie Digi. I love this graphic. So I want you to go ahead and maybe kind of pull this out of the slide. You can print it up, save it. Lizzie Digi, we need to know, one, what's our normal dig level? So if you look at her bracelets, 0.5 to 2. Some references say 1.8, so close enough. But if a dig level is high, they can become toxic. We need to know that dig increases myocardial contractility. So what that does is it's going to slow the heart rate, but it's going to make the heartbeat better, so to speak. And we always need to look out for GI or central nervous system signs. This is going to indicate adverse effects. So when you look at Lizzie Digi, one thing you're going to notice when you look at the picture are these little circles around her head, and those are called halos. You see her face is green. That's pretty important too. You've got her lab values on her bracelets, and if you look at her lamp and her chair, they look wiggly and blurry. So hopefully this will help you remember some manifestations of digoxin toxicity. All right, so let's talk about digoxin, a cardiac glycoside. Now again, these are going to increase the force of the heartbeat. They're going to slow the heart rate down, again, improving cardiac output. And these are typically the second line treatment for heart failure. And digoxin has a very narrow therapeutic range. Remember her bracelet, 0.5 to about 2. Again, it causes a more forceful heartbeat, and that's what we want. We want the heart to slow down a little bit, but we want it to beat better. The primary benefit of DIG is its ability to increase that contractility, and this is one of those meds that I said has a positive ionotropic action. When the contractility is better and the cardiac output is better, this is going to alleviate some of the symptoms that you see with heart failure and improve exercise tolerance. This may cause increased urine production, and that is a desirable reduction because we want to reduce blood volume, and that connects with hypertension. This can also help with relieving distressing symptoms of pulmonary congestion and peripheral edema, again, the left-sided and the right-sided heart failure. One thing DIG does too is it suppresses the sinoatrial node and slows electrical conduction through the AV node. This then lends itself to, when you go back to patho and you're thinking about electrical conductivity in the heart and the SA node to the AV node, when we start talking later in your capstone course about dysrhythmias, it wouldn't be uncommon to see this medication because it has an effect on that electrical pathway. Administration alerts and considerations. When you are giving digoxin, you need to take an apical pulse for 1 full minute. You need to note the rate, rhythm, and quality before administration, period. If the pulse is below whatever parameter is set by the provider, then you are not going to administer that. And that parameter is typically if their heart rate, apical pulse, 1 full minute, is 60 beats or less, then you are not going to give that medication. We got to be mindful about that digoxin level, and you have to look at those levels before you administer this medication. If the level is high, based on parameters, and again, I keep 2 in my head, 2.0. Sometimes it could be 1.8, so you have to look at your policies. Then again, you're going to withhold the dose. And again, caution in geriatric and pediatric patients because their renal and liver function may not work as good. Adverse effects could be neutropenia, dysrhythmias, and of course, DIG toxicity. The most dangerous effect of digoxin is its ability to create dysrhythmias, particularly in patients who have hypokalemia and impaired renal function. So again, we got to look at potassium levels. We've got to look at renal function, bun and creatinine. Diuretics can cause hypokalemia, and they're often used in conjunction with digoxin. So you need to be extremely mindful and carefully monitor your patients. Other adverse effects include nausea, vomiting, fatigue, anorexia. But here's where we're going to start going into DIG toxicity. Visual disturbances such as seeing halos, a yellow-green tinge, or blurring. Again, do periodic serum drug levels, and you're looking at that DIG level, make sure it's in a therapeutic range. Some specific considerations: patients that have AV blocks or dysrhythmias unrelated to heart failure should not receive digoxin because this is going to worsen their block or their dysrhythmia. Digoxin should be administered with caution again to older adults, and patients with renal impairment should receive a lower dose of digoxin. Drug-drug interactions. Digoxin just interacts with many drugs. Again, it can cause, if you're taking digoxin with diuretics, it's going to cause low potassium. They're more at risk for dysrhythmias. If it's used with ACE inhibitors, potassium supplements, again, we're looking at hypokalemia. That then can lead to dysrhythmias. If digoxin is given with other ionotropic drugs, and this can happen too, this is just going to potentiate the effect. So the 2 meds together are going to make the heart contract more forcefully. And if calcium is administered with DIG, calcium IV, it can cause dysrhythmias. So that's a lot. So you just, one takeaway is you need to be very careful with digoxin and look at a client's medication history. Lab values, we want to look at DIG levels again and potassium levels. Keep your eyes on those. This DIG has a herbal consideration, and you don't want clients taking ginseng with this, and it's very popular. So ask your client about those herbal and food medications or interactions. Treatment for overdose, DIG overdose can be fatal, which is why you need to understand DIG toxicity and the manifestations that you're going to see. There's a specific therapy, it's an IV infusion of a medication called Digoxin. And what this is it contains antibiotics specific for digoxin. So this med has a particular medication that will be given for overdose treatment. Yay, beta-adrenergic blockers, one of my favorites. And how I remember these are I like to think as Babs, like to LOL, or laugh out loud. So a lot of times when you see adrenergic blockers, they are going to end in LOL. Remember, there's two different types of beta-adrenergic blockers, or maybe three. They can be beta 1, and that's a selective, and it's going to work on the heart because I only have one heart. They could be beta 2, and they're going to work on the lungs because you have two lungs, or they can be a combination of both. On the second half of the screen, I kind of put some need-to-know information when we're talking about beta-adrenergic blockers. They are going to cause bradycardia, or can cause. We need to be mindful of blood pressure, of course, and watch for it going too low. These can also have an effect on the lungs a little bit, so we need to watch for bronchial constriction. I think we talked about this before, but probably not a whole lot, but they can mask low blood sugar. And that's because they slow down the heart rate. And one of the things happens when we have low blood sugar is our heart rate tends to increase and we get cool and clammy and all that other stuff. But these meds can kind of interfere with a client being able to see that. So we need to make sure we teach them. And this is one medication you don't want to give if a client is in what's called a heart block and it's greater than 1st degree. Now, I don't want you to know all those yet because they're going to come later, but just know that contraindicated in heart blocks greater than 1st degree, and those blocks will be 2nd degree or 3rd degree. So let's focus on Lopressor, beta-adrenergic blocker. How these work is they're going to slow the heart rate, reduce blood pressure. They have an inotropic effect, and they're going to reduce the workload of the heart. So this is the key, folks. This is what we're trying to do. We're trying to help the heart not work so hard. They block cardiac action of the sympathetic nervous system, and that's how it slows down the heart rate and blood pressure. This is used to treat symptoms of heart failure and slow the progression of congestive heart failure. Again, it's a selective beta 1, and it may have an effect on beta 2 receptors in the bronchial smooth muscle, which is why we have to worry about that bronchial constriction. It can be combined with other heart failure drugs. They can all be combined, folks. Not to make it confusing, but they can. That's why you need to know the difference. They can be combined with ACE inhibitors. It wouldn't be uncommon to see a client to be on a beta blocker, an ACE inhibitor, a loop diuretic, a calcium channel blocker, especially if they're in renal failure. But we'll talk about that later. Lopressor is approved also for angina, which we're going to talk about, hypertension, of course, and reducing complications following an MI. You need to be mindful during IV administration of this drug that your client should be on continuous EKG monitoring, probably telemetry most definitely, maybe a 12 lead. Always watch their blood pressure. It should be continuous if you're given IV, and check pulses frequently. Again, you're going to assess pulse and blood pressure before oral administration. If the pulse is less than 60, you'll want to hold that medication if you have that order, or you want to request parameters to do so. If they're hypotensive, you're using your clinical judgment. You should have parameters, but if you don't, then you need to ask for some. It's okay to pause for a minute and not administer the medication and make a phone call. This medication can come in extended release, so whenever you have an extended release, enteric coated, anything like that, do not crush or chew. Don't think we need to say this again, but be mindful of our geriatric population, not only due to renal function, liver function, but they are more at risk for dizziness and falls. Some common adverse effects: fluid retention, worsening of heart failure, fatigue, low blood pressure, bradycardia, and potential heart blocks. You need to monitor your heart failure patients that are on this medication. They may also have abnormal sexual function, drowsiness, fatigue, and insomnia. This medication does have a black box warning, and that is that abrupt withdrawal is not advised in patients that have angina or heart disease. Your dosage should gradually be reduced over 1 to 2 weeks, and the drug should be reinstituted if angina symptoms develop during this period. And you'll know more about that when we talk about angina. This medication is contraindicated in patients with cardiogenic shock, sinus bradycardia, heart block greater than first degree, hypotension, and overt cardiac failure. It should be used with caution in patients with asthma and those who have a history of bronchospasm. So let's go back to that little visual. The beta 1, one heart, the beta 2, two hearts. We need to worry about that with this medication, even though it is a beta 1. Drug-drug interactions, we need to be mindful with this medication if it's being used with digoxin. Here we go. Digoxin just messes with so much stuff. So just a general rule of thumb in your practice, if your client is on dig, be careful. Okay, make sure you look at that. We definitely want to make sure we tell female clients that oral contraceptives may cause increased effects of this medication. Again, no alcohol, okay? Lopressor is going to affect, we talked about hypoglycemic effects of insulin and other oral hypoglycemic medications, so that's a drug-drug interaction. And we need to make sure if they're taking verapamil, this could increase the risk of heart block or bradycardia. Lab tests that you want to look at specifically for Lopressor are uric acid, lipids, potassium, bilirubin, creatinine, and BUN always. There are no herbal or food interactions, and treatment or for overdose could be given a medication called atropine, and this is going to reverse the bradycardia or the slow heart rate that's caused by the overdose of Lopressor. You can also, hypotension can be reversed by vasopressors, and I'll just kind of throw a vasopressor out for you now so you can kind of plant that seed, and one of those is called Dobutamine. Okay, so phosphodiesterase inhibitors, Primacor, as I'm going to call it moving forward. These block the enzyme phosphodiesterase. They're going to increase calcium from myocardial contraction, and they're going to cause positive inotropic responses and vasodilation. This is going to help the heart contract. It's going to decrease afterload, and this is for short-term therapy only. The medication is generally preferred because it has a shorter half-life and fewer side effects. It's given only IV, and it's primarily used, again, for short-term therapy of heart failure. This drug has a rapid onset of action, and it has immediate effects with the myocardial contraction. Sorry. When this medication is administered IV, you always have to make sure you use a microdrip set and an infusion pump. And this leads me to, let's start thinking about, this is why we have to figure out how many drops per minute we need to give in medication. So definitely want you to practice your dosage on how to figure out and do drops per minute. Adverse effects could be hypokalemia. It's in all of these almost. Hypotension, of course, and this can cause dysrhythmias. The most serious adverse effect is the dysrhythmias. So again, your client should be on continuous EKG monitoring. Blood pressure needs to also be continually monitored. And there are some less serious side effects such as headache, nausea, and vomiting. Contraindicated in clients that have hypersensitivity to this medication, or if they have pre-existing dysrhythmias that we're aware of. You should be cautious when administering this medication if your client is on digoxin or dobutamine or any other inotropic drug. It's going to increase the effect of the drug. And sometimes we want a good effect of a drug, but too much of a good thing is never really good, is it? No lab tests again, but we always look at our renal panel, basic metabolic panel, of course. No herbal food interactions. This medication again can cause hypotension, and you can treat this with normal saline bolus or a vasopressor. With our nursing process, we always are going to start with our assessment. Again, get a complete health history, vital signs, need to know the urinary output, you need to know their cardiac output, reasons for medication, and their patient's knowledge base with that. Current diagnoses, or common diagnoses, I should say, with any of these medications. Decreased cardiac output, excess fluid volume, deficient knowledge related to drug therapy, and risk for reduced cardiac tissue perfusion. When we're planning, basically we want to make sure we have a decrease in those signs and symptoms of heart failure. Ultimately, clients will want to improve their cardiac function, and again, understanding of drug therapy and when to report drug side effects. As far as implementation and specific nursing interventions, we're given cardiac meds, so would it make sense to monitor them on telemetry? Always observe for side effects of medications. Daily weights are so very, very, very important. We'll talk a little bit more about that with patient education. Look at those serum drug levels. Again, if a client's on DIG, look at a DIG level. Potassium, just look at the potassium. Every time you have a patient, look at the potassium. Always observe for signs of toxicity, so you should know DIG toxicity manifestations and what to do if a client is toxic, and always monitor all electrolyte levels. Evaluation, as always, we want to make sure client met goal or outcome. So considering teaching and education, because this is a huge piece of these medications, we need to teach our clients the symptoms of heart failure, of course, and what these medications are going to do. They're going to slow the heart rate, increase contractility, reduce the heart load or the workload of the heart. You should always teach your clients how to self-monitor their pulse and blood pressure. Now, they're not going to have a stethoscope in the house, most likely, unless they have a nurse in the family or something of that nature, but you can buy devices, for example, at Walmart, that are easy to put on. You can do your blood pressure, and it's going to do the pulse for them, so they always want to monitor that daily. You got to talk to them about lifestyle changes. We always think about prevention. So one thing, a lot of things we could do. Diet. What are we doing with our diet? Healthy lifestyle choices, exercise. Always to teach your clients to take the precise dose of the medication. Don't double up the dose if they miss. Specifically for ACE inhibitors, that we want them to get frequent labs so we can look at the CBC, BNP, and renal panel. They need to know what manifestations are for hypotension, and they always need to know when they're getting labs, as well as they need to be mindful of potassium levels. Again, reteach your patients that the response time for ACE inhibitors could be weeks or months. We want clients to have restrictions with sodium, so we want maybe a low sodium diet, maybe one of those things called a DASH diet, and again, no salt substitutes, and they're going to have potassium restrictions, so you got to know which meds you need to not have potassium with and which ones you need to have or can have potassium with. Don't use other medications, over-the-counter herbals and vitamins if they have an effect with ACE inhibitors. When we're thinking about beta-adrenergic blockers, you have to teach your client to monitor for worsening symptoms. So remember, those beta-adrenergic blockers can have an effect with the respiratory side of the house, so we want to make sure we do that. Again, monitor blood pressure, pulse, report pulses below 50, report signs of symptoms of worsening heart failure. This is why you need to know the left and the right-sided heart failure. So if they're having shortness of breath, pink frothy sputum, or increased pitting edema, they need to let their provider know. Also, you got to teach them how to do daily weights and talk to them about that. Anything 2 pounds a day or more, this is bad. When you're teaching clients to do daily weights, they need to do them at the same day, same time of day, on the same scale every day, so there's consistently. And again, teach them not to stop beta adrenergic blockers abruptly. They should be tapered. When we're thinking about cardiac glycosides and digoxin, we always have to be mindful for dysrhythmias. Again, look at the renal function, drug interactions, teach your clients that no restriction on use with antidiarrheal or antacids. They need to watch their therapeutic levels, and clients that are going to be on DIG at first need to clearly be explained about digoxin and that therapeutic range and what manifestations come with digoxin toxicity. Still going to monitor the pulse, blood pressure, weight, and foods with potassium. So think to yourself, what kind of foods have potassium in them? Common ones, bananas and potatoes. And there's a few other. For the phosphodiesterase inhibitors, again, look at the potassium levels, monitor teacher clients' blood pressure, pulse, have them be astute for irregular or rapid heart rate that could lead to a dysrhythmia, and any fevers, usually over 101 degrees Fahrenheit, or most particularly if they have chest pain, okay? And if it's going IV, then we go back to our fundamentals with ensuring that our IV access is good and there's no signs of infiltration. If you have any questions about this presentation, please post your questions in the Prep for Exam 3 forum of your Blackboard course, and have a wonderful day.